Okay, we were discussing about angiotensin receptor blocker, ACE inhibitor. So, if we want to stop these drugs, we have to stop this drug within 2 working days of notification of pregnancy and offer alternatives. Okay, advise women who take thiazide or thiazide-like diuretics that there may be an increased risk of congenital anomalies and neonatal complications if these drugs are taken during pregnancy. To discuss alternative hypertensive treatment, antihypertensive treatment with the healthcare professional responsible for managing their hypertension if they are planning pregnancy. Advise women who take antihypertensive treatments other than ACE inhibitor, ARBs, thiazide, thiazide-like diuretics that are limited evidence available has not shown an increased risk of congenital malformation with such treatment. Okay, treatment of chronic hypertension. Offer pregnant women with chronic hypertension advice on weight management, exercise, and healthy eating. Lowering the amount of salt in their diet, continuing with existing antihypertensive treatment if safe in pregnancy, or switch to an alternative treatment unless sustained systolic blood pressure is less than 110 millimeter mercury or sustained diastolic blood pressure is less than 70 millimeter mercury or the woman has symptomatic hypotension. Offer antihypertensive treatment to pregnant women who have chronic hypertension and who are not already on treatment if they have sustained systolic blood pressure of 140 millimeter mercury or higher or sustained diastolic blood pressure of 90 millimeter mercury or higher. When using medicines to treat hypertension in pregnancy, aim for a target blood pressure 135 by 85. So the target blood pressure should be 135 by 85 millimeter of mercury. Consider labetalol to treat chronic hypertension in pregnant women. Consider nifedipine for women in whom labetalol is not suitable, or methyl-dopa if both labetalol and nifedipine are not suitable. So first line drug is labetalol, then nifedipine, then methyl-dopa. Base the choice on any pre-existing treatment side effect profiles, risks including fetal effects, and the woman's preference. At the time of publication, some brands of nifedipine were specially contraindicated during pregnancy by the manufacturer in its summary of product characteristics. Refer to the individual summaries of product characteristics for each preparation of nifedipine for further details. Offer pregnant women with chronic hypertension aspirin 75 mg to 150 mg once daily from 12 weeks. Offer placental growth factor based testing to help rule out preeclampsia between 20 to 36 weeks and 6 days of pregnancy if women with chronic hypertension are suspected of developing preeclampsia. So, women with chronic hypertension suspected of developing preeclampsia should be offered placental growth factor based testing to rule out preeclampsia between 20 to 36 plus 6 weeks pregnancy. In women with chronic hypertension, schedule additional antenatal appointments based on the individual needs of the woman and her baby. This may include weekly appointment if hypertension is poorly controlled, appointments every 2 to 4 weeks if hypertension is well controlled. So, antenatal checkup if well controlled BP 2 to 4 weeks interval, and if poorly controlled BP weekly interval. Follow up. Timing of birth. Do not offer planned early birth before 37 weeks to women with chronic hypertension whose blood pressure is lower than 160 by 110 millimeter mercury, with or without antihypertensive treatment, unless there are other medical indications. For women with chronic hypertension whose blood pressure is lower than 160 by 110 millimeter mercury after 37 weeks, with or without hypertensive antihypertensive treatment, timing of birth and maternal and fetal indications for birth should be agreed between the woman and the senior obstetrician. If planned early birth is necessary, offer a course of antenatal corticosteroid and magnesium sulfate if indicated, in line with the NICE guideline on preterm labor and birth. Postnatal investigation, monitoring, and treatment. In women with chronic hypertension who have given birth, measure blood pressure daily for the first 2 days after birth, at least once between day 3 and day 5 after birth, as clinically indicated if antihypertensive treatment is changed after birth. In women with chronic hypertension who have given birth, aim to keep blood pressure lower than 140 by 90 millimeter mercury. Continue antihypertensive treatment if required. For choice of antihypertensive during the postnatal period, see the section on antihypertensive treatment during the postnatal period, including during breastfeeding. Offer a review of antihypertensive treatment 2 weeks after birth with their GP or specialist. If a woman has taken methyl dopa to treat chronic hypertension during pregnancy, stop within 2 days after the birth and change to an alternative antihypertensive treatment. Because it causes postpartum depression. Offer women with chronic hypertension a medical review 6 to 8 weeks after the birth with their GP or specialist as appropriate. Assessment and treatment of gestational hypertension. In women with gestational hypertension, a full assessment should be carried out in a secondary care setting by a healthcare professional who is trained in the management of hypertensive disorder of pregnancy. In women with gestational hypertension, take account of the following risk factors that require additional assessment and follow-up. Nulliparity, age 40 years of above or above, pregnancy interval more than 10 years, family history of preeclampsia, multifetal pregnancy, BMI more than 35 kg per meter square or more, gestational age at presentation, previous history of preeclampsia or gestational hypertension, pre-existing vascular disease, pre-existing kidney disease. Offer women with gestational hypertension the tests and treatment listed. What is the management? Hypertension between 140 by 90 to 159 by 110 millimeter mercury. And another division is severe hypertension 160 by 110 millimeter mercury or more. So admission to a hospital is not required below 160 by 110 millimeter mercury. Do not routinely admit to hospital, but severe hypertension admit, but if BP falls below 160 by 110 millimeter mercury, then manage as for hypertension. Antihypertensive pharmacological treatment. Offer pharmacological treatment if BP remains above 140 by 90 millimeter mercury, because the target is 135 by 85. Target blood pressure is 135 by 85 and severe hypertension target is also 135 by 85. Blood pressure measurement. How frequently? Once or twice a week, depending on BP, until BP is 135 by 85. And severe hypertension every 15 to 30 minutes until BP is less than 160 by 110. Dipstick proteinuria testing. Use an automated reagent strip reading device for dipstick screening for proteinuria in a secondary care setting once or twice a week with BP measurement, and in severe hypertension daily while admitted. Blood test measure full blood count, liver function test, renal function test at presentation and then weekly. Measure full blood count, liver function, renal function at presentation and then weekly. Placental growth factor based testing. Carry out this test on one occasion if there is suspicion of preeclampsia. In both cases, okay? So in both cases, only on one occasion if suspicion of preeclampsia. Fetal assessment. Offer fetal heart auscultation at every antenatal appointment. Carry out ultrasound assessment of the fetus at diagnosis and if normal, repeat every 2 to 4 weeks. If clinically indicated, carry out a cardiotocography or CTG only if clinically indicated for advice. And in severe hypertension, carry out ultrasound assessment of the fetus at diagnosis and if normal, repeat every 2 weeks if severe hypertension persists, and CTG only if clinically indicated. Offer placental growth factor based testing to help rule out preeclampsia in women presenting with suspected preeclampsia. For example, with gestational hypertension between 20 to 36 plus 6 days. Consider labetalol to treat gestational hypertension. Consider lifedipine for women in whom labetalol is not suitable, and methyl-dopa if labetalol or nifedipine are not suitable, based on the choice on side effect, risk factor, including fetal effect and women's preferences. Do not offer bed rest in hospital as a treatment for gestational hypertension. Do not offer planned early birth before 37 weeks to women with gestational hypertension whose blood pressure is lower than 160 by 110 unless there are other medical indication. For women with gestational hypertension whose blood pressure is lower than 160 by 110 millimeter mercury after 37 weeks, timing of birth and maternal and fetal indication for birth should be agreed between the woman and senior obstetrician. If planned early birth is necessary, offer a course of antenatal corticosteroid and magnesium sulfate if indicated. In women with gestational hypertension who have given birth, measure blood pressure daily for the first 2 days after birth, at least once between 3 to 5 days after birth, and as clinically indicated if antihypertensive treatment is changed after birth. In women with gestational hypertension who have given birth, continue antihypertensive treatment if required. Advise women that the duration of their postnatal antihypertensive treatment will usually be similar to the duration of their antenatal treatment but may be longer. Reduce antihypertensive treatment if their blood pressure falls below 130 by 80 millimeter mercury.